Welcome back to the deep dive. Today, we are tackling a topic that is, I think, universal for any parent or caregiver: evidence-based pediatric fever management.
It really is. It's probably the single most common reason, that a child is brought into an urgent care or an
The
ED.
urgency department, yeah.
And this deep dive is so necessary because the sources you pulled together, these are syntheses from major players like the American Academy of Pediatrics, the AAP, and top children's hospitals. They show the whole standard approach has, well, it fundamentally changed.
So our mission today is to really cut through all that noise, strip away the old myths, and just pull out the definitive, evidence-backed do's and don'ts.
Exactly.
We want to make sure that if you find yourself up at 2 a.m. with a hot kid, you know exactly what to do
Yeah.
with a plan that's really focused on comfort.
We're moving from the anxiety of just staring at a thermometer to the clarity of the clinical evidence.
Okay, so let's unpack that core philosophical shift first, because this is really where the modern approach just breaks with the past.
It's a huge shift.
The goal was always get the temperature down, back to 98.6 or 37 Celsius as fast as you can. But the new guidelines, they pivot completely.
They do. They state that the primary objective is no longer about normalizing the child's temperature.
It's what then?
It is strictly comfort-focused care.
That feels like a huge weight off the shoulders.
It is, because when you look at the actual physiology, a fever is, it's a normal and generally helpful process. It's just the body's defense mechanism kicking in.
So it's not dangerous in itself.
Not inherently, no. In most cases, we aren't hurting the child by letting their temperature run a little high. What we are hurting is their well-being, if they're in pain, if they're distressed.
So the new mantra, and this really is the key takeaway from this whole thing, is treat the child, not the number.
That's it. That's the whole philosophy in a nutshell.
So if a child has, say, a 103-degree fever, but they're playing, they're drinking, they seem okay, you might not need to intervene.
You might not. But if they have a 101 and they're miserable, crying, refusing to drink, then you intervene immediately.
It's about the kid, not the device.
Precisely. And the research volume on this is just staggering. Our sources show that a recent search on this topic, it pulls up over 7,200 results.
Wow.
And they're expecting hundreds more just in the next year. It just shows you how much confusion there's been.
That explosion in research tells a story, doesn't it? It's evidence that inconsistency has been a real problem in the field. I saw some studies noting that even among, ED nurses, there were big variations in practice.
Absolutely. The need for a standardized, clear, evidence-based guideline is paramount. And when you look at that standardized approach, the research consistently points to two strategies.
Two first-line strategies.
Right. Proven to improve both temperature and comfort. They are our top priorities.
Okay, so that takes us right to the first pillar of treatment, the one everyone thinks of: oral antipyretics.
Yep. We're talking acetaminophen and ibuprofen. The evidence for these is just incredibly strong. They reliably reduce fever and they improve comfort. As long as they're dosed correctly, and this is so important, it has to be based on weight.
Always on weight, not age.
Always. If you do that, they are safe and effective. They are the clear first-line treatment for any fever-associated discomfort.
So if they're both first line, is there any reason to pick one over the other? Because you brought forward a really interesting network meta-analysis that compared them head-to-head.
Yes. That analysis was published in 2024, and it did provide a nuanced comparison. The finding was that ibuprofen is cited as being slightly more effective than acetaminophen for temperature reduction.
Slightly more effective.
Just for the temperature reduction part, yes. It's a small statistical edge, but it's worth noting in a clinical setting.
So if it's a bit more effective, why isn't it just the only recommendation? Is there a catch?
Well, it often comes down to the specific situation. For example, you can't use ibuprofen in infants under 6 months old.
Yeah, that's a big one.
Right. So for that younger age group, acetaminophen is often the go-to. Also, some guidelines suggest you should be careful with ibuprofen if there are any worries about dehydration or kidney function, since it's an NSAID.
A non-steroidal anti-inflammatory drug.
Exactly. So you want both in your toolkit, really. It depends on the child's specific clinical picture.
That makes a lot of sense. Now, what about combining them? Alternating, acetaminophen, then 3 hours later, ibuprofen. We hear about that all the time.
The alternating schedule? Yes. The official guidelines are actually very cautious about this. While some data suggests it may reduce fever a little faster, the guidelines point out that it makes the whole process way more complex.
And that increases the risk of mistakes.
A huge risk of accidental dosing errors, especially for tired parents in the middle of the night.
Simplicity is safety. So, if your goal is comfort, you stick to one. But you know that ibuprofen might have a slight edge for just bringing the number down in kids over 6 months.
You've got it. Now let's move to pillar B, which can sometimes get dismissed as, just general advice. Hydration.
Right, pushing fluids.
Yeah.
Why is this so strongly recommended if the sources are pretty clear that liquids don't actually lower the temperature directly?
It goes back to the physiology of the fever itself. When the body's temperature is up, it's working hard to cool itself down. Things like sweating, breathing faster,
And that uses up water.
a lot of water. It leads to something we call insensible fluid loss.
And what exactly is that for those of us who aren't clinicians?
Insensible fluid loss is it's the water you lose that you don't really notice. It's not like urination. It's the moisture that evaporates from your skin or that you lose just by breathing. And when a child has a fever, that process just ramps up dramatically.
So the body's basically burning through its fuel and losing liquid in the process.
Precise statement, Lee. The research is unambiguous here. While liquids don't directly lower the fever, they are absolutely critical for preventing dehydration.
And a hydrated kid is a happier kid.
A hydrated kid is more alert, has a better clinical status, and can just tolerate the symptoms of the fever so much better, even if the thermometer reading hasn't budged much.
So you're treating the systemic stress.
That's half the battle right there.
Okay, now we're at my favorite part, dispelling a big old myth. The one that guidelines now explicitly say to avoid. Ice bags, cold packs, or the dreaded cold bath.
This is a practice that really, really needs to be retired. For generations, the thinking was just heat, apply cold. It's intuitive.
Seems to make sense.
But the clinical evidence backed by the AAP is crystal clear. You have to avoid aggressive external cooling for fever.
So tell us why. What's the physiological reason that this thing that feels so right is actually so wrong?
It all comes down to a defensive response. When you put something cold, like an ice pack, on the skin, the body just perceives this rapid external temperature drop, and in response, it triggers vasoconstriction.
Vasoconstriction, that's a narrowing of the vessels, right?
Yeah, exactly. The blood vessels near the skin clamp down to stop heat from escaping the core. So instead of drawing heat out, the cold pack basically acts like a blanket. It traps the heat inside.
It's literally the opposite of what you're trying to do.
It is. You want the body to radiate heat, but the cold makes it hold on to it, and it actually gets worse. The sudden cold triggers shivering. Shivering is just your muscles contracting, and it's the body's way of actively generating heat to fight off what it thinks is external cold.
So you're making the child's body produce more heat.
You are actively increasing their metabolic heat production. It could even raise their core temperature.
So not only does it not work, it makes the child miserable. And that distress and shivering could actually make the fever worse.
Yeah.
That is a definitive, evidence-backed DO not T.
Absolutely. The sources are clear on this. External cooling is just ineffective and uncomfortable compared to antipyretics. There's no PubMed supported benefit for it.
Let's shift back to something that is helpful, even though it's non-pharmacologic. Comfort. The guidelines strongly support simple things, like parental holding or hugging.
Right. And while holding or skin-to-skin contact doesn't physiologically lower the fever, its value is just immense.
Why is that? I mean, it seems obvious, but what's the clinical reason?
It's because it addresses the other half of the problem, anxiety and distress. A child who is anxious or scared is going to fight treatment, refuse to drink, and just generally tolerate their symptoms much more poorly.
And comfort care changes that.
A hug, a quiet environment, it reduces that psychological distress. They become more cooperative with hydration. They tolerate the fever better. It's a key part of the whole protocol.
So let's tie this all together. Give us the practical protocol for the most common scenario. A child has a fever, but they're generally tolerating it okay. They're hydrated, they're alert.
The protocol is, it's remarkably simple. First, you prioritize comfort, reassurance, a quiet room, and you're constantly offering fluids for hydration. Second, you only use oral antipyretics if they become uncomfortable or distressed.
If they're crying, can't sleep, refusing to drink.
Exactly. If they are playing happily with a high temperature, we stick to the mantra, treat the child, not the number.
And you always have to watch for red flags.
Always. You monitor for things like lethargy, any trouble breathing, or if the child is under 3 months old. That always warrants an immediate evaluation.
That provides so much clarity for the vast majority of viral cases we see. But we do have to talk about the exceptions, the boundaries.
A crucial caveat, yes.
These guidelines are for a generally healthy child. But the research also covers these highly specialized populations. which reminds us that this comfort first model has its limits.
It does. While this approach is standard for general urgent care, the literature you shared covers really specific areas. For instance, a child with an underlying condition like cancer who develops what we call fever and neutropenia.
And neutropenia is a low white blood cell count.
Yeah.
Why does that change everything?
Because in that child, a fever isn't just a normal response. It's treated as a clinical emergency. It could be a sign of a very serious systemic infection.
Because they can't fight it off.
Their immune system is compromised. So the protocol is immediate, aggressive, broad spectrum antibiotics, usually IV. There's no waiting to see if they're comfortable.
And what about other conditions like Kawasaki disease? I saw that mentioned.
Right. In a case like Kawasaki, which involves this prolonged high fever and inflammation, the temperature itself is aggressively treated with specific anti-inflammatories because the fever is a sign of a process that can lead to, serious cardiac complications if you don't treat it.
So these specialized cases just reinforce why having clear standard guidelines for the common stuff is so important. But clinicians always need the full context.
Absolutely. The nuance is what takes this from just a list of tips to actual clinical insight.
Perfect. Let's bring it all home then.
Yeah.
Let's synthesize the definitive takeaways from this deep dive.
Okay, for the standard patient in urgent care, the summary is crystal clear.
First, do use oral antipyretics like ibuprofen or acetaminophen, but only when the child is actually uncomfortable or distressed.
Second, prioritize hydration. Push those oral liquids to prevent that insensible fluid loss and keep their clinical status strong.
Third, do offer comfort, holding, reassurance, anything to reduce anxiety and help them tolerate their symptoms.
And the big, firm, evidence-backed, do not use ice bags, cold packs, or cold baths. They cause vasoconstriction, they trigger shivering, and they actively increase metabolic heat production and discomfort.
So now that you understand the goal is comfort and support, what's the final thought we should leave with?
Well, while most fevers are from self-limited viral infections, the research does encourage us to maintain what you might call therapeutic awareness. Meaning some studies are investigating whether a lack of response to antipyretics. So the fever and distress don't really improve after that first dose might actually be a diagnostic clue.
A clue for something more serious.
It can sometimes be associated with more serious conditions like bacteremia. So monitoring how the child responds to that first dose of ibuprofen isn't just about timing the next dose. It becomes another piece of data, a prompt for continued vigilance. It's definitely something worth mulling over.